Hi, my name is Nick, and I'll be discussing basilar invagination, also known as BI. Let's begin with what BI is. It is a congenital or developmental condition in the craniovertebral junction, which results in the prolapse of the odontoid process into the foramen magnum. BI cases are mostly irreducible, meaning they will require surgery. This sounds quite serious. Let's see what causes it. Some congenital conditions that predispose patients to BI are rheumatoid arthritis, Chiari malformation, and Klippel-Feil syndrome. Don't have any of these conditions? Well, another cause of BI can be trauma to the anatomical structures involved. You may be wondering what these structures are. And if you were, here they are. Odontoid process, C1 and C2 vertebrae, atlantoaxial joint, occipital bone, and the cervical spinal cord are some of the most relevant anatomical structures involved in BI. Over here in diagram C, you can see a sagittal CT scan of a patient with BI. The ventral compression of the medulla here is quite concerning, and according to Zhu et al., it leads to severe neurological injury. Don't worry though, there are treatments for this condition. As you can see in diagram G, the patient underwent transoral atlantoaxial reduction plate fixation, otherwise known as TARP, and obtained decompression of the medulla. You can see the significantly high odontoid process and distorted relationship between C1 and C2, causing compression on the medulla pre-operation, in comparison to post-operation over here. And here on the anterior surface of the vertebrae, you can see the TARP plate. You may be thinking, well, this is fantastic, but is it the only treatment? No, it's not. There are many available treatment options, such as occipital cervical fixation, which we'll call OCF, and anterior transoral release with posterior instrumented fusion, which we'll call AAFP. But TARP achieves superiority for several reasons. First of all, TARP is performed with the patient supine during the entire operation, while other methods require patients to turn over from supine to prone, which, according to Zhu et al., creates instability in the atlantoaxial joint, risking damage to the spinal cord. Also, TARP's operative time is significantly less when comparing studies by Zhu et al. And Lahiri et al. Precisely, TARP was, on average, 28 minutes shorter than AAFP and 98 minutes shorter than OCF. Considering extended operative time is important because, according to Cheng et al., it may lead to an increase in surgical team fatigue, which opens up possibilities for technical errors. Furthermore, there is no external scarring since the operation is performed intraoral only. Other methods require a posterior incision, but no one wants a huge scar on the back of their head and neck. Lastly, TARP had more favorable radiological results post-operation, which include atlantodental interval, cervical medullary angle, and bone fusion, which were all derived from studies by Zhu et al. And Lahiri et al. Now, what exactly is TARP? It is an extremely delicate and intricate surgery, which not all surgeons can perform. First, an incision is made in the posterior pharyngeal wall through the oral cavity. You can see the spinal cord compression here, and if you recall, Zhu et al. Claimed that this leads to severe neurological injury. Next, 2 screws fix the TARP plate to the anterior surface of C1, right here. After that, a temporary screw is inserted into C2 through the plate, right in there. Then the upper and lower arms of the forceps are installed onto the plate. The handle is closed to achieve vertical distraction of C1 and C2, which you will see right here. You can see the vertical distraction occur. Then after that, a nut on the upper arm is turned to push C1 back for horizontal reduction. After that's done, vertebral screws are inserted into C2 and the temporary screw is removed. Then incisions are closed and the patient lives to see another day. Thank you for listening, and I hope you found BI and TARP as interesting as I did.